Welcome all of you to our webinar on health systems in fragile, on the health systems recovery from COVID-19, working across the humanitarian development peace Nexus. This webinar is organized by the thematic working group in fragile health systems in fragile and conflict affected states in close collaboration with EMRO in Cairo. And hence the session is moderated by representatives from both. So you'll see from EMRO, you'll see Dr. Ali Adalan, but he is also a steering committee member of our thematic working group. And myself, Egbert Sondorp, I'm one of the co-chairs of the thematic working group. So I think it's a very timely webinar, as we all feel probably that the big urge of the whole COVID-19 epidemic is a bit subsiding. We see less and less lockdowns and other restrictions. We see slowly, at least in the countries of concern to us, we see some increase in vaccination rates. So it seems to be there's a bit more time now to take stock, to learn lessons, what happened, but also start preparing for the future waves of COVID, but also future similar epidemics or others of some sort. And then in particular, we have to think of how to further strengthen the health systems that have been affected. And for us in our webinar and of our thematic working group, of course, our particular concern is around countries that we usually refer to as fragile and conflict affected settings. And you can characterize them in a number of different ways, but what they typically have in common, an already weak health system, which has been further affected in most countries by the epidemic. And one of the reasons why it's difficult to rebuild, to go into the recovery mode is the fragmentation of those systems and other systems in those countries. And part of the reason of that is that you often see a multiplicity of actors working alongside and not always in great coordination. And I think it's in particular around those themes that a couple of years ago, the concept of the humanitarian development peace nexus has been developed, it being promoted. There are some good experiences here and there, but I think it's great now to see where are we, how can we apply the principles of the nexus to this situation where we would like to strengthen the health systems again, who are recovering from COVID-19. So that's very much the topic of today. I will try to explore this from a number of different angles, thanks to the panelists we will have on board, but also you as participants. We count on you to ask questions, which we can address later on in the session. So what can you expect from this session? We will start with a first brief introduction about our thematic working group, which not all of you may be familiar with, and that will be done by Barbara Profeta, who is also a steering committee member of our thematic working group. And then we give the floor to Ali Adalan, who is kind of Mr. Nexus. And he will give us a brief account of what the HDPN is about. And before he will continue to take the floor, and he will introduce you our four excellent panelists we have today. They will give a brief presentation, each of them based on a set of questions. Well, Ali will introduce them and what they will talk about. And then finally, we'll have a good opportunity to answer questions, to have a Q&A sessions. And so we very much count on you to ask the questions for that session, and you can post them. I think you're all familiar with this phenomenon these days, in the Q&A box, preferably. And then we try to see, maybe combine a few questions and then ask the panelists to respond to them. So that's about what I want to do in terms of an introduction. So I would like to give the floor to Barbara and tell us a bit more about our thematic working group.
Thank you very much, Egbert. Good morning, good afternoon, or good evening, everyone. As said already by Egbert, my name is Barbara Profeta. I work for the Swiss Development Corporation in Switzerland, but I'm also a member of the TWG FCAS, as we call the Thematic Working Group on Fragile Conflict-Affected Settings. So my role today is to give you an overview of what we are and what we do. So bear with me a second. I will show to you my screen, and hopefully you will see it. 1 second. Can you all see my screen?
Not yet. No.
Is it okay? Not yet. Is it Murphy's Law? Now?
No.
Again? Now?
Not yet, but I'm sure it is close.
It's, do you want me to share it?
Otherwise, you can send it to me, Barbara, if you would like to share it. But I understand that you have 2 screens, so it would be up.
Yes,
Okay.
it is here.
Okay, perfect.
You see something?
We can see your screen.
Yeah, you probably see my screen, but
So you need to send.
the only problem is that we lost Barbara. Barbara, are you still there? So just a second.
Can you hear me?
Yes.
Are you seeing my screen? Hello? I don't.
We can hear you, but perhaps you could try to reshare your screen.
Not see my screen.
No.
Let me try again. Sorry, I apologize for this. It worked just minutes before we started.
It's coming.
Now?
Yes, it's there. So now you still have to do the display setting thingy at the top.
Okay. Yes, I'll do that.
Yes. Upper one. Yeah. No, it's okay.
Now?
Yeah.
Okay, I'm really sorry for this. So I was saying that my role is actually to introduce you very briefly to what the thematic working group does and is. So the thematic working group FCAS is one of 10 thematic working groups of the Health Systems Global Network, and it has been active since 2013. Today, the thematic working group on fragile and conflict-affected settings is an active group of more than 1,500 members, and it aims to connect and engage a range of actors, including researchers, policymakers, donors, practitioners, health providers, educators, civil society, and the private sector. And the goal is basically to advance health systems research in fragile and conflict affected settings, as the name of the thematic working group says. The TWG creates networks between different actors, the ones mentioned above, but also others, all who wants to engage, to share knowledge, information, and resources, and promotes advocacy for health systems and health systems research. The group is managed by a steering committee led by Egbert Sondbor, who just talked before me, and is supported by an expert advisory group of about 11 members and a communications coordinator. More information about the group, you can actually find it on the link that's provided on your screen. Members are very welcome to contribute to the TWG with ideas, or they can also support specific activities and tasks. And we actually encourage you to get in touch with us if you're not already in touch at the email that you can see on the screen. And particularly if you think you're able to provide some support, or if you're enthusiastic to engage in one of our activities. The thematic working groups, the thematic working group FCAS communicates through a LinkedIn group and a Google group, and many of you might already be a member of one or the other. But if you're not, we encourage you to join both groups, and you find the link there, but we will be sharing this slide with the active hyperlinks so that you can actually just click on them and get registered. Today's webinar is part of a series of activities that is planned by the thematic working group, focusing on 3 themes. Particularly this year, there were 3 themes, and then as we move on, we might actually change the themes according to the interest of the different members and the various initiatives that one or the other member suggests. So the first theme concerns health systems governance in fragile settings, and we had a webinar to kick off the reflection on that particular theme in September last year, which you can access through the link that is provided on your screen. The second theme reflects on the short and long-term impact of COVID-19 in FCAS. We had a first webinar on this theme last autumn, looking at community health workers. And today's webinar is the second webinar of this particular series. And the third theme is in the making. It's aiming at reflecting on the concept of fragility, given its contested nature. So please stay tuned with us for more information on this particular theme. That was all for me. I'm sorry you had to suffer to get through this very short presentation, but I hope it provided some interesting overview of the role and work of the thematic working group on FCAS. And now I would like to give the floor to Ali Ardalan. Thank you very, very much.
Thank you so much. I appreciate Barbara. Yes, I'm going also to share my screen. Can you see the screen?
Yes, it's coming. You can.
Okay.
Full screen, yes. Yeah.
Okay, thank you so much. I appreciate. My name is Ali Ardalan. I'm a member of the esteemed committee of FCAS and the regional advisor and head of health systems emergencies lab in WHO EMBRO. I have a pleasure to moderate this part of the webinar. Please let me to start with introducing our distinguished panelists. We have with us Dr. Paul Spiegel, Professor and Director of the Johns Hopkins Center for Humanitarian Health, a distinguished worldwide expert in the area of health in emergencies. We have the pleasure to also have Mr. Francesco Mucetta, a Senior Advisor at the Grant Management Division of the Global Fund, actually close partner, supportive partner to many initiatives around the world. Ms. Nemo Hassan is with us today, thanks to her. She is the director of Somalia NGO Consortium that actually is the platform that many Somali-based NGOs actually are the members. And finally, we have Ms. Clara Offen with us. She's a health system researcher at the Institute of Tropical Medicine at Antwerp, also a consultant with the Health Systems in Emergencies Lab, and basically main contributor into many of the guidelines and profiles we have developed thus far. Before actually going to the main part of the panel, I just want to quickly provide an overview of the subject, the humanitarian development peace nexus, and its application to the health sector. So as we know, it's not a new term. Actually, it's supposed to be a solution for all the problem. In fact, it was featured in several earlier initiatives, such as the EU linking relief, rehabilitation and development, resilience approach, conflict-sensitive approaches to development and humanitarian assistance, and early recovery approach to humanitarian programming. However, the Nexus approach tries to go further by combining the objectives of these initiatives together. The point of this renaming and rebranding is that after several years of the commitment that was made to adapt the triple nexus or HDPN humanitarian development peace nexus, its conceptualization and operationalization still remained underdeveloped. In the context of the health, among many other partners, actually, with the general program of work of the WHO tried to implement this approach and bring the agenda for humanity with the agenda of sustainable development goal through defining priority activities on their 3 billion goals that you see that are related to universal health coverage, health and well-being of the people, and also health emergencies. In Eastern Mediterranean region, that actually is one of the most problematic region of the world, and today we have 9 countries with actually active clusters and humanitarian response plans. WHO has established a team called Health Systems Emergencies Lab as a kind of the Nexus style program to bridge the 2 main streams of the work, health system strengthening with health emergency operations, and also trying to link with the peace related discussions and initiatives. We tried to basically institutionalize the program and answering some critical questions in a systematic way. And what are those critical questions? What is the nexus and how can be applied for health? How can be operationalized and how can be measured and or evaluated? For this, we tried first to start with developing a guide that also we had a consultation meeting, and both Dr. Sondrup and Dr. Espigel were there as part of the consultation, and Clara was actually supporting the development. And we try to introduce this as not a standalone process, but embedded in the wider Nexus process and integrating within the existing framework, such as HRP, United Nations Cooperation Framework, etc. The other question was, okay, what is the level of the or status of the operationalization in different contexts? We came up with the idea of the profiling of the operationalization, and they introduce a tool that can help with the monitoring, technical cooperation with the countries, capacity building, partnership, and also advocacy. So these are, you see the actually the first round of the profiles for 6 countries published, and the second editions are done for actually 8 HRP countries. And some other more deep studies, for instance, this is that was done in Sudan to analyze the this humanitarian development interventions and their nexus in health sector. The question was that if inside the organization and outside, the partners are familiar with the concept, know how to implement that and evaluate that, we came up with the training course with the Doha Institute, and we piloted in last year. Hopefully, we'll continue this year, inshallah, in Doha with in-person attendance. During this process, we learned a lot. One of the key lessons is that actually we have a group of the program project activities that are formally labeled as the Nexus or known as the Nexus, such as the project, actually EHNP, or Emergency Health and Nutrition Project, supported by World Bank, implementing by WHO and UNICEF in Yemen. There are other projects such as the Sabah Nexus project in Libya that actually in a very classic way tried to implement the different elements of the Nexus, starting from the joint actually assessment, defining collective outcomes, including health, as you see in this slide, and the other elements of the Nexus implementation cycle. Or what is now trying that under the traditional Afghanistan, the transitional Afghanistan aid architecture is under the discussion to see, even in this context, how the Nexus approach can be considered. But at the same time, there are many activities, projects that are not labeled formally as the Nexus, or the Nexus term is not used, but actually has the same spirit or similar methodology, or at least part of the classic Nexus methodology, and we call them Nexus style activities. Like, for instance, for years, EU has been supporting the Libya health information system to not support the humanitarian response, but also make them a kind of the sustainable program in the country. So, or the similar activities. I'm not going to take time for this at this moment. There are challenges, classic challenges, starting from while the benefits of the Nexus are widely recognized, its approach as implementation is still in challenge, maybe because of inadequate technical capacity to operationalize that. A still different structure and way of working between humanitarian development actors, the way that the donors define the projects, and etc. And also very limited role of health sector in large P pillar of the Nexus, while we can do a lot under that small P, that is societal piece. At the same time, there are opportunities like a global commitment, political will, while maybe there is no money available specifically for the Nexus, but there are funds that can be utilized. The SDG-related, health-related SDGs and the similar high-level reference documents that the countries can help a lot with defining the collective outcomes, like the similar to the national Syria national policy and health strategy that can nicely define the collective outcomes of the recovery and resilience building in that country. And the other, when COVID happens, actually basically not brought many challenges to the world, but at the same time opened the room for testing, for instance, the different approaches, including the Nexus in that context. We had a lot of examples that how basically the different organizations, partners tried in Sudan, actually in Libya, in Afghanistan, bringing the different elements of humanitarian response with the actually development thinking or the opportunities together. And while, for instance, supporting the COVID labs in Afghanistan, at the same time building capacity for the lab actually sector in that country. Put aside the recent crisis in Afghanistan. The Libya, the same, the establishment of health sector coordination group in Tripoli, and etc. And a project in Sudan like HDPN project to strengthen preparedness and response of the health systems addressing the COVID. So having, so all these challenges and the opportunities, we thought that maybe it's good to also have a discussion more deep on that and try to answer these questions. What are the opportunities and challenges caused by the pandemic for the implementation of the Nexus for Health in terms of joint assessment, formulation of collective outcomes, funding, coordination, etc.? Who should be involved in implementing the Nexus? What is the role and place of actors and stakeholders, such as local NGO, the community and governments, particularly in the setting that we have multiple governing parties? How can accountability be promoted? Who should be accountable? What kind of accountability mechanism we can think of actually to not guarantee, but at least facilitate the implementation, given the different actors usually have their own agendas. So what I propose is that basically, and this is the aim of this webinar, is that asking our expert panel that what do you think? So basically, please feel free to answer any of those questions or combination of those based on your own experience. If I may, I would invite Professor Spiegel to basically answer the questions and reflect his views. Great. Professor Spiegel, over to you.
Thank you very much, Ali and Egbert and colleagues. I've already learned a lot just from your slides, Ali, so you're doing a lot that I wasn't aware of, which is wonderful. Perhaps just some background. We're doing also at Hopkins a small amount.
May I ask you to get closer to the mic?
Yes.
A little.
Yeah. How is this? Is this any better?
Better, thank you. Thank you.
So we're doing a bit of work on this issue on the Nexus with a USAID program called Momentum, which is focusing mostly on maternal child health. And we did some background as well, research, and then we're going to be doing some case studies in other countries, certain countries. Some of them may overlap with yours, which will be wonderful. But what we tried to do, and I think many people have tried to do, is develop a framework to try to at least address this. And I know you've done that as well. For us, we came in with some sort of core elements. And I think each of these need to be addressed, and they have the challenges as well as possibilities to improve. So number one is leadership and governance. Number two is coordination. Number three is financing. That's the one that I'm particularly focused on. Number four is analysis and planning. And number five is information management. And what we tried to do, and again, focusing overall on the Nexus, but with a specificity on maternal child health, what we found is that there has been a tremendous amount written about this. I would say more in the theory than in action. And then when we tried to look at specifics in certain countries, case studies, there have been many, But also what we found is a lot of it was more anecdotal, or at least talking about what was implemented, as opposed to trying to measure and to come out to say, well, what were the results? And one of the, I would say, big challenges I found is that it's so multifactorial, because you have to have your development actors, your humanitarian actors, obviously the governments, and from potentially international NGOs to local NGOs, UN, private sector. And so when you start looking at what everyone in theory could be doing to make a difference ultimately to the individuals and the communities, it's a challenge to be able to document what everyone is doing to have a final outcome. And even trying to look at some of the indicators to measure it has certainly been complex. COVID itself has exacerbated, let's say, or at least shown all of the gaps and the gaps in existing health systems and the weaknesses in many countries. That's clear. But beyond the health systems, what COVID has also shown is I would say possibly increase because of the way information now is shared, but the misinformation and then the disinformation. So another big challenge, I believe, is not going to be just who is doing what, but how to work with the communities and to make sure we do risk communication and community engagement. So even if we did have the right people doing the right things, and right is too strong of a word, but at least going in that direction, COVID has shown the skepticism, let's say, in terms of vaccines or other information that I think is going to be that will stay and could possibly exacerbate in the near future. The other, I won't speak too long, so I'll maybe just talk a bit about financing. What we've seen consistently, and it's still there, I was in Afghanistan, as you know, Ali, for a while, is we still see divisions in terms of, clear divisions in terms of development funding and humanitarian funding. The reporting on them, the indicators, everything still is quite separate. Yet when you look at what they're all trying to do, they're either complementary, or at times they can still be duplicative. And so one of the I would say challenges, or in terms of, now let's go to your last question, in terms of accountability, it would be a wonderful challenge to many of the donors to be able to look at how they are funding places like in Afghanistan and others, South Sudan, and trying to, while they may not be able to change their massive bureaucracies and their systems, trying to at least align them sufficiently in a much more complementary manner, so we can actually know who is getting the funding for what, and looking at the various indicators to see if there is an effect. Community engagement, yeah. I think I'll stop there. There's a lot more to say, but I'm sure they will come out as we speak with the others. Thank you.
No, thank you so much. I appreciate. Actually, you set the scene for the next panelist, Mr. Mucheta, dear Francesco. So it seems everybody is referring finally to the donors. So what do you think?
I know, and it's very important actually that the donors should align. And no, thank you very much. And thank you very much, Paula, for setting the scene. There are perhaps a couple of comments I'm going to make on the pandemic, because it's been quite a challenge for the Global Fund for the traditional programs, but also how to respond to the pandemic within our mandate and within national programs. As you know, the first response has been providing in-country flexibilities to reprogram their own grants to respond immediately using the existing structure, the existing capacity, stretch capacity, but existing. And one of the elements that has been very supportive, especially in complex settings, was actually the community engagement. Communities proved to be extremely reliable and resilient to the pandemic, and was one of the strengths of the response. So in terms of that was the first response, and then probably, we set up a mechanism to finance in-country preventing and diagnostic interventions on COVID. But that, just to say that also in that element, we never really done by ourselves in the response to pandemics, especially in complex emergency. We've been very much using the existing coordination with the humanitarian partners. In a number of cases, we've been participating to meetings with humanitarian partners in collaborating to the response, because of course in crisis, the pandemic had a major impact on the system with the major gaps and support. So that's been part of the conversation we had in the past. So I think it was, I wouldn't say it's an opportunity, but was really that the previous experience within the Nexus has been supporting our response to COVID. The Global Fund, it's quite an unusual sort of a structure in the sense that we are very development, but on the other side, we cannot afford to leave anyone behind, especially with HIV in any settings. So regardless of the profile of the country, we will be working in any portfolios, and that drove a little bit of conversation on how to do it. And therefore, we've been joining all the discussions about the Nexus and how humanitarian development and peace partners can work together to jointly invest and support the programs in those settings. And very recently, we supported the OECD DAC recommendations on the Nexus. It was a sort of a political expression of a support. We are not member of the OECD, but I think that's been paving the way to having some sort of internal reflections on how the Global Fund should do more on the Nexus. And at the end, we come up with some sort of 3 key areas. One is the one that Ali was actually presenting in terms of internal culture and understanding by having an adapted training module. There's a Nexus Academy. Some of our colleagues have been attending the Nexus Academy. The way we've been thinking on the internal training is very similar to the one that Ali was referring to as a sort of original training with a few modules for internal use first, but then we would like also to use it as a training at external level for country coordination mechanism, for principal recipients and any other partners in country that would like to use this training. And again, it's an initial sort of effort to fill some sort of a gap in terms of understanding challenges, understanding the principles, understanding existing coordination mechanisms, and we're going to push for that one. The other stream that we focus on is actually, this is a year for replenishment, and therefore we're going to be starting again the whole allocation cycle and new funding coming through next year. So we focus also on internal processes, how the Nexus or the coordination and the integration of the different elements of the Nexus will be part of our communication externally with countries. So we do have information notes, guidance notes, but also internal documents, and how that could be also reflected to the way we engage with the partners at a different level, starting from country dialogue through the country coordination mechanism, and how we've been, and we are supporting already the country coordination mechanism to ensure that there's a participation of the humanitarian partners in complex emergency. There's a participation or coordination with the humanitarian platform that has been already included into the work plan for some of those country coordination mechanisms for the next year. So this is very operational in the way we would like to translate the Nexus into our own internal process and documents and the way we work with partners in complex emergencies. And the last stream is very much operational, building on the experience in Mali and Central African Republic recently. And I know it's not part of your region. We had a very good experience actually in Afghanistan, but the way we've been addressing challenges in Mali has been very much to focus on the decentralized level. So how can we implement within that sort of a complex setting around the Mopti area, which is a lot of conflict and displacement, and the northern part of the country that is not controlled by the government? How can we engage with the humanitarian partners at the last mile level, service delivery level? It has been very interesting because it's also responding to one of the points that we learned that we can engage much more with the local communities, much more with the local NGO, much more with the national NGO to deliver services, because at the end of the day, what we care is actually the last mile delivery and the population being received. And building on that sort of experience, we've been developing what we call it as differentiated approach for the Global Fund model, which is really replicating some of those experiences in Mali and elsewhere. We have a very good experience actually in Afghanistan with the Sehat Mandi initiative and the NGOs, but also, building and try to really develop some sort of a methodology can be replicated elsewhere. We had a second pilot in Central African Republic, which is ongoing. So I'm not going to be able to give you more results, but we are replicating some of those methodology, but each portfolio is different. CAR is not South Sudan, is not Mali, but the engagement and the coordination of humanitarian partners, the integration of their own sort of programs and planning is very much the same. So we are very much encouraging and using that sort of a Nexus framework for this approach. And I'll pause here. Thank you very much.
Well, thank you so much. Actually, you referred to many critical points. Among all, one was that you actually confirmed that this Nexus implementation has different layers, like intra-agency or intra-organizational Nexus, and then it goes to the sector and then goes to the wider Nexus coordination. And this is true about the WHO. We have the health emergencies stream. We have the actually health systems work stream. Donors are the same, EU, Global Fund, and the others. And it's very important that basically that Nexus inside the organization is built first, and then continue with the other layers. And then you refer to the support and the role and importance of the NGOs, local, international, in implementation of the Nexus approach of the Global Fund. So I'm going to ask Ms. Hassan about her experience during the COVID in implementation of the approach in Somalia. Over to you, Mimo.
Thank you very much, Ali, and good afternoon, everyone. Great insights into what's happening globally on the Nexus approach. And as I hear from everybody, I think the importance of actually continuing with that work. If I just start with maybe giving a little bit of background of what the Somali NGO Consortium does. It's a platform, it's a forum that brings together both local and international actors that operate within Somalia. We have it fluctuates because it's a membership organization which is renewed annually, so we can go between 100 to 115 so far, and hopefully we'll continue to grow in ensuring that we have a more coordinated voice of the NGOs that operate in Somalia. We've also, because of localization as well, we also make sure that we have a 50-50 representation in everything that we do. We focus on advocacy, joint advocacy, we focus on representation, coordination, and information sharing, which are all very key and critical elements to implementing the Nexus approach as well. Now, the challenges and opportunities across the various sectors actually remain the same. Maybe they are experienced slightly differently. For the health system, and especially for a country like Somalia, where there's been 3 decades of conflict, instability, climate shock, and disease outbreak, which weakens the health system and makes it one of the vital sectors that we need to ensure and strengthen, is actually important to synergize across the spectrum. As you've presented, Ali, this conceptualization of the Nexus, it's been already six years, and now we're still talking about how do we do this together after 6 years of having this declaration, groundbreaking declaration, and also ensuring there's new ways of working to better the situation of the communities that we are supporting. So if I give you maybe a little bit on the local actors, and I think local and international NGOs are already implementing the Nexus. They're already wearing multiple hats, particularly local partners, where they're developing, doing development activities and projects, humanitarian, and also contributing to the peace and reconciliation of the communities where they serve. I think if we're looking for a good example, I think that's where we can find good examples. It's usually the hierarchy. Up you go, the more siloed the sector is. So I'm glad the Global Fund is here, and I hope maybe later we can hear about how maybe they're intercoordinating with other donors as well. It's really important that the donors level are also coordinating. I know the humanitarian partners usually talk about the difficulties maybe synergizing between the development and the humanitarian, but I think we need to focus on the commonality rather than differences. There is so much commonality between the sectors that can be leveraged to ensure that we are more successfully ensuring that we are not situations like Somalia after 30 years is still in the same situation. I'm sure a lot of you are aware that currently the Horn of Africa, but in particular Somalia, is suffering a terrible humanitarian crisis due to the drought, and partners are now talking about famine prevention in the country. So coming back to the impact of COVID-19 and what we've learned in terms of opportunities and what we found as challenges is that actually it brought out the fragility of the whole system. The pandemic hit, borders were closed, organizations and staff have left. And those who remain behind are the communities and those with the communities, particularly local partners who are always at the forefront to respond. I'm not sure who said, but we talked about partnerships. There has to be equitable partnerships. We need to empower those who are on the ground and supporting the communities who continued. There's resilience in terms of COVID-19. The prediction when the pandemic hit was that it will affect Africa a lot harder than it will hit in the other, but that wasn't the case for whatever the reason. And there's been a lot of misinformation, disinformation, but I think when the community mobilization happened, the leaders spoke, it started to build trust between the communities and the responders. So the health system is already weak and was weak in a fragile context. That wasn't supporting the community as a whole totally. But yet again, when we have alone actually, doing the global pandemic. So basically, it put pressure on already weak systems, but it highlighted the opportunities that we have as stakeholders to ensure that we are promoting this way of the Nexus way of programming as an approach to empower and synergize those local partners, particularly the local NGOs. So awareness raising has happened quite often in Somalia, and now COVID vaccine it's increasing. It's increasing when people are building trust. Now, the following question said, who should play part in the Nexus development peace approach? I think everybody, all the stakeholders have an equal and important role to play. And unless we support and complement the work that we're all doing and improve our coordination, then we will be where we are in the next years to come. I hope not. So coordination is really important. Local, like I said, local and international NGOs are already, most of them are multi-mandated, are already doing development, doing humanitarian, and doing peace. So it's really important that we build on those priorities. We also need to ensure that we are focusing on what can work together what are the commonalities, identify the commonalities, and ensure that we have collective outcomes. Financing is really important, which has reduced in across the various sectors as well, and that we need to ensure that funding is available, it's flexible, it's multi-year, that has the beneficiaries or the communities that we're supporting, whether it's during the planning stages, designing stages, or whether it's developing strategies that can ensure that those multi-mandated entities and stakeholders are actually working together and are able to speak on the same note, the same level. In terms of the accountability, I think we're not reinventing the wheel. Everything Nexus stands for is basically what we're doing on our own, separately. But what we need to be doing is, what the Nexus is promoting is that cross-sector complementarity and ensuring that we are leveraging where there is leverage, ensure as well. So I think it's really important that we are strengthening the system. We're not reinventing the wheel, and we should focus on what works well and see what we can learn from each other to ensure that we're promoting the well-being and the development of those communities who are affected. I think I'll leave it at that, and back to you, Ali.
Well, thank you so much. Later, you can answer this question that if you feel equal with the donors and also the government of Somalia in terms of the publish. Okay.
Is that a question? That's a question?
That's a question. You can think you can answer it later. Okay. So,
Okay.
okay. Thank you so much. So, Ms. Clara, over to you. So basically, I was reviewing the guide that we developed together. And that guide, we mentioned that after 4 years of the Nexus conceptualization, still the implementation is under the development, and it's challenging. How is the situation now? Over to you. After 6 years.
I'm glad you asked me a slightly different question, because I think most of the other 3 questions have been well covered by the other panelists. So yeah, I'm glad I have a slightly different question. And to answer the question, I think, like some people have alluded to already, we're still, we haven't advanced that much from where we were 2 years ago when we developed the guide. There's still a lot of talk about the Nexus. There's still a lot of things that are happening that could be classified as Nexus activities, but they're not really recognized as Nexus activities. But one cause for optimism, I guess you could say, is the COVID, and for instance, the fact that there's now more of a focus on building systems, because we saw the importance of health systems, not just of disease control or just of health security as a standalone thing, but really the fact that health systems are kind of like the bedrock of this kind of work. And I think that helped to really focus the attention of the different actors and stakeholders, which is an opportunity, because then it allows a window of opportunity to kind of for advocacy. It helps to open the discussion, I guess you could say, especially not just with donors, but also with people who work at the operational level about, the importance of strengthening the underlying systems and not just acting in a reactive manner. Of course, this will continue to happen. We see what's happening in Ukraine right now. It's, again, an emergency is an emergency because it happens without forewarning, and you have to act and respond to that. But after that initial kind of response, then there's a need to already immediately start thinking about the long term. That's still not happening as quickly, but yeah, so we haven't made as much progress as we could have made, but there is progress, and COVID can be seen really as an opportunity to kind of push further in that direction. I think I'll stop here. Over.
Thank you so much. So basically, I wish to hand over to Egbert.
Yes, thank you, Ali. Thank you all panelists for your excellent contributions. So indeed, it's time for having some Q&A. That's about to start. And if any of you would have some questions, please post them in the Q&A so we could see what kind of questions there are. And see if we could answer them. So yeah, the problem is that with this kind of systems, we do rely on your written questions. It's difficult to give the floor to everyone. That's always a limitation of this kind of webinar. So there is one participant, Fuad, who likes to talk. I'm not sure if it's possible to give you the floor. That's maybe up to the organizer to see to give us that opportunity. But otherwise, maybe Ali, because you just had a question which you already raised to Nimo. Could you maybe repeat that question? And because it seems an important question to see how we deal with feeling equal.
Yeah, so first the question, okay, so two questions, one to Nimo, one to Francesco. The question to Nimo is that if you as an NGO, and actually consortium of NGO, feel equal with the Francesco and the government of Somalia, okay? So this is a question for you. And the question for Francesco is that actually, the question for Francesco is that in health system, when we discuss, and you are a public health expert anyway, so when we discuss, we say we are integrated. You know, basically it's so difficult in many contexts to divide, to differentiate our operation and divide to purely humanitarian to health system strengthening, specifically when it comes to the protracted situation, Somalia. In many cases, it's so difficult to distinguish, okay? And that they are the donors that guide us to basically in different streams and directions. So what do you think about that? So Nimo, over to you, please.
Thank you, Ali. I was looking at the chat and question A to see if the question came from the audience, but I think the question came from you, Ali, and you are provoked. It's a more provocative question, I guess, but I will try and attempt to answer it in a more diplomatic way. I absolutely think. I mean, we talk about equitable partnerships, and donors themselves talk about having partners. So, in that sense, if we have an equitable partnerships, and these are, I'm talking about the implementers, those people who are doing the actual groundwork, then I think it's really important that we are donors are seeing them as an equal partner that have an important job to do on behalf of the donors and on behalf of the people who donate the money the donors manage. So I think if we look at it from that angle, then we should see that. And it's a different role, a different job altogether, but equally important. Now, and also the donors do really need to take a more leadership role in terms of coordinating among themselves. If donors are implementing similar projects in the same sectors in one particular country, then I think having a more coordinated approach in terms of the strategies and the objectives, or at least identify where there is commonalities. I think that will only benefit the communities, the vulnerable people that we're trying to support. We're trying to lift them out of poverty. So I think it's really important that we are maybe better coordinated. I mean, there is coordination does take place. It happens at the country level, but I think it's really important that we need to double that. We need to scale up on that. When it comes to the government, of course, service provision and the responsibility, the civic responsibility lies within the government when it comes to serving their own citizens. But where they need support, and in countries like Somalia, where the governments are recovering, it's a federal system. Somaliland is completely independent and it's doing their own thing. You have federal member states that have their own parliaments, their own national priorities. So I think it's really important that the government is taking that leadership to ensure that they are coordinating the stakeholders who are operating in that particular location to ensure that we are efficient and effective in responding to the causes that we are responding to. Like I said, in the Somalia context, these different member states, whether it's Somaliland, they're actually at a different development stages. Insecurity is not a blanket statement that covers the whole country. The whole country is not in a state of emergency. There are relative stability and peace. If you look at the private sector in Somalia, it's actually thriving, and that's a sector we usually miss in leveraging, where we can engage the private sector to ensure that we are maximizing the effect and the impact of our programming. I think I will leave it at that, and I hope I answered your question.
Thank you very much, Nimo. That was a good explored answer to that question. I think Ali also asked a question to Francesco. In the meantime, we have given word that it is possible for also other participants to directly talk. So after Francesco, we will give the floor to Fuad to formulate his question. That's possible. And then we also already have a question for Paul, which you can see in the Q&A box. But first, Francesco.
Okay, thank you much. I think it's important for when it comes to our perspective in investing in fragile settings, especially in a health system in fragile settings, the distinction between what we call implementing partners and what we call the investment partners, in a sense that therefore, due to a volatile situation, often in time we rely on international organizations or UN organizations to be the principal recipient of our investment. But the ultimate implementers of a global funding actually the national programs, the health system. So that's the way we secure that the way we are financing activities is always integrated within the system. We already starting building the system within a critical situation. So that, and we rely a lot, of course, also on the in-country partners to be able to support us on integrating those interventions. So for instance, we had this agreement with MSF in Central African Republic to provide the data and integrate the data into the national data system to make sure that we have the same sort of visibility in data for the whole country. And if I also use again the example of Mali, there are two PRs, a principal recipient. One is the Minister of Health, and then the other one is a national NGO. So through the national NGO, then we implement in the northern part of Mali, but also in the rest. So we still work with the system unless there is a very critical situation, but we tend to focus and prioritize the system. And perhaps because I saw the comment, maybe just to set the scene to Paul for the follow-up comment, the experience in Afghanistan for us and Ukraine later on has been very much engaging with the humanitarian partners from the day one. And as a sort of a development institution, we rely a lot on the cluster, on the UNHCR, on any existing sort of interventions to share our own sort of availability of funding in country. While, I mean, if I give you the example of Ukraine, we're still working with the national program, with the Ministry of Health, with the civil society, with the whole organizations. So that, and thanks to those organizations, we're able actually to work in the country. So, you know, surprising in the context that it's a war like Ukraine, we are operating thanks to the civil society and to the Ministry of Health. I'll pause here. Thank you.
Thank you, Francisco. That's well, you mentioned the word Ukraine. We'll soon touch that a bit more in depth through Paul, who has some recent experience there. But if things are okay, Fuad, you should be able to talk. If you unmute yourself, yes, please.
Well, thank you very much. Really, I really appreciate and good afternoon, everyone. So good to see, you know, faces that I really miss to see. Actually, allow me just to comment quickly and argue more than just, you know, raising question. It's inspired by the observation by Paul about the division of funding between humanitarian and the development. My argument is it could be that behind this sort of division, it could be because of the traditional model of health system, of 6 building block framework health system that we keep, you know, building all these issues around it. Given that in the last few decades, but maybe focused more on the last decade, that the type of crises and the overlapping are actually of a nature of more global, that, you know, affect each other and not just overlapping, but also interacting. That actually leads to this issue that the current health system framework become really difficult to respond to that, given the fluidity of issues, refugees, pandemic, you know, funding, all these issues. So my argument is to what extent there's a need not just to build this issue of nexus, you know, around, I mean, which is definitely is needed, but also to keep seeing or doing like a sort of deep revision of the this health system model. And, you know, and the other issue is, you know, the role of political determinants. You know, Paul, I think this division, there's an interest for have this division between, you know, humanitarian and development. And actually, this is in many countries, in many cities, this is used to do some negotiation about I don't know, getting more fund or, you know, being contacted or connected with donors. I think, you know, also ignoring sometimes this political factor in shaping, you know, not just the funding, but also the response to the crisis. So it's more comment and argument, and I will stop here. Thank you very much for allowing me not to write all these unorganized issues. Thank you.
Thank you. It would indeed be a bit problematic to start writing. No, this is great that we can talk. So, and also for others, if you would still like to comment, I see a hand already up from Najibullah. So soon you get the floor, but others are still open to give the floor. But I think you, Paul, you were kind of addressed, I think, by Fuad. So maybe you would like to respond, and maybe also Ali, because I think Fuad is a bit challenging some of our underlying reasoning behind the Nexus. Paul.
We like challenge. Yeah. Welcome challenge.
Absolutely. Let's see, in terms of Ukraine, yeah, and when you compare, and I see now Safi will speak on Afghanistan, but it's so, when you compare Ukraine and Afghanistan, as Francesco was saying, it's completely different. And a lot of it is because of, one, sanctions or no sanctions. So who various donors are able to work with, meaning not possible to work with, for the most part, with the Taliban, whereas with the Ukrainian government, it's very much being the Western powers are working very closely with the Ukrainian government, obviously. And then also, I think what Nemo said is that we often think about Ukraine, and there's conflict everywhere, like in Somalia, but of course that's not the case. So there are many calmer places, areas in the Ukraine, and the government is functioning. So it's very interesting to see and very positive to see that that the donors and the humanitarians that are there are actually working under the coordination of the government, which is quite strong and has its own ways of working. So I think all of that has been positive to if anything can be positive of that particular war. In terms of the Nexus, I want to just very briefly talk about two components. Within Ukraine, because it is so acute right now, I think the focus is more on the emergency. But there is a group within the Ukraine considering reconstruction, and they're already thinking very clearly about how they will make things different, in particular ensuring that everything is going to be coherent with the EU, of where they want to go. So I think that's interesting. They're already considering that. The refugee setting, which is where I was working more on, or really solely on, it's also very different from, it's different. And I think what's been happening is they've opened up, unlike in many other countries, and there are a lot of contradictions, they've opened up access to the refugees to be able to work, to be able to go to school, and to have the same access to healthcare as existing nationals, which is positive. It would just be positive if they did this for all people seeking asylum and not just Ukrainians. But that being said, there has not been a huge amount of stress compared to other crises, because it's primarily been women and children. And so hospitals, beds, and occupancy have not dramatically increased. It's mostly been a healthy population. My concern, I think, and others in thinking about the Nexus is it is also showing weaknesses in systems. For example, in many of these surrounding countries, there aren't enough general practitioners. Many have moved from Eastern Europe to Western Europe, and number one. And then number two is they're aging out because younger physicians don't wish to be GPs. So yet they are the gatekeepers to the health system. And so one area that is going to be challenging, but there's not going to be an easy solution, is to work in terms of increasing the access of these refugees to general practitioners. And there's been a lot of different solutions that I won't go into now. A lot of it requires, or at least one of them would be requiring to allow Ukrainian healthcare workers to work in these countries. Many are trying to do that, but it's going to take time because of language and because of certification and supervision. I'll end there, but there's so much more to say in that particular crisis. Over.
Thanks, Paul. Ali, I challenge you to take up the challenge of Fuad. You have.
Okay, so actually, I think what Fuad mentioned is true. Okay, there are factors that we can call them socio determinant of health, or socio-political determinants that anyway affects our thinking, our operations, and also at the end the health of the population. And however, we need to acknowledge that this is the real life. So in each country, basically with facing the protracted emergencies, there are up and down of the situation, progress and regress of the development. And in many cases, political agenda is behind. None of them happened by chance. The recent situation in Afghanistan didn't happen by chance that Taliban came to power in like few days. Okay, so for sure there are some like bigger agenda is going on worldwide. What we can do as a public health professionals is whatever like all the doctors do. So basically, we needed to deal with continue providing the service as much as possible we can, at considering that particular point time of the emergency. So in the context of the Nexus, what we can do is always have updated the conflict analysis to inform our humanitarian and development planning and their bridging. This is, I think that's unfortunately the factor that we are dealing with, and there is no way to escape rather than keep analyze, keep inform our planning over time. Over to you.
Thank you, Ali. Let's move on, and I think we have seen the hand of Najibullah Safi, and he is known to be closely linked to Afghanistan, so maybe he can add some of that perspective. Najibullah, are you there, and are you ready to talk? Yes, can see.
Thanks a lot. Thanks a lot, Edinburgh, and thanks for allowing me to talk. Though I'm not working in Afghanistan now, but there were multiple references for Afghanistan. So I just want to make a few comments. In Afghanistan, over the last, I would say, few years, we never had any clear-cut Nexus approach, but there were multiple activities, particularly during the ongoing COVID-19 pandemic. That the emergency funding came to the country and that is invested in areas which is used for overall health system strengthening. For example, at the beginning of pandemic, we didn't have the capacity to diagnose COVID in a single lab. But now, today, through emergency funding coming for COVID, we have 40 labs in 34 provinces of Afghanistan across the country. And they are well equipped, the staff is trained, and they are capable not only to diagnose COVID, but also they are contributing to the other aspect of health system, including communicable disease, outbreak response, and they're busy with that one. At the same time, we had multiple regional labs and in each region, and those regional labs were also supported through humanitarian funding, and now they have even the staff is now supported till end of 2023 through humanitarian funding, and they're functional and they're working not only for COVID, but also for other public health outbreaks across the country. In addition of that, another example that humanitarian funding was used for something health system, the construction of oxygen plant through COVID-19 funding. Multiple oxygen plant in Kabul and also in different regions were constructed, and those oxygen plant are producing oxygen today, not for COVID patient, but for the normal ordinary patient and other emergencies. So what Ali was referring initially, that possibly we don't have any written approach of Nexus, but there are Nexus type activities, or they are somehow not clearly put in that context, but the emergency funding, humanitarian funding is used for development, and that continue to provide more opportunities for strengthening health system across the country. I stop here, but would be happy to contribute if there is any specific question related to the experience of Afghanistan based on my past experience. Thanks a lot again for giving me the opportunity to say a few words. Over.
Thank you very much to reflect on that situation, and yeah, if there's anyone who would like to follow up on that, there's definitely still the time and opportunity to do so. And we were also shown in Ali's presentation a very intriguing slide, of course too short on the screen to really study, but about a new framework in Afghanistan that would be interesting to look at. But let me first, so people can think about it and maybe raise their hand if they would like to comment on Afghanistan or any of the other remarks which have been made. Still go back a bit to Clara, because you have been, I think, engaged with what they call the Africa Recovery Framework, that is specifically from COVID, and how you see this related to the Nexus approach.
Thank you for the question. So I was, like Egbert said, a bit involved also with developing the African Union Recovery Framework. And I don't know if I would say the Nexus was very prominent in that framework explicitly, but again, it's the same kind of issue, which is that there was, it seems that there's a lot of Nexus style collaborations going on. So for instance, it was the assessment was done in a kind of multi-sectoral way. It wasn't just the health sector by itself, it was just all the different sectors working together, different actors giving their input. And okay, while there was no, like no label of the Nexus, it kind of featured prominently in the way that the exercise was being conducted. So I don't know if I would say that the Nexus, we could have called that process the Nexus process, but it was in the style of the Nexus. I think that's as much as I can say. Over.
All right, thank you, Clara, for this explanation. I don't see any immediate hands raised, but there are still two questions which did come in the chat box. So they are a bit similar, but I think they have a slightly different approach. But let me read them both, and then I would ask any of the panelists if they can think of how to approach this. The first one is from Abia Ahmad, and she makes in particular a link with the Nexus. How can it be successful while at the same time what we see is a massive reduction in official development assistance in fragile and conflict affected states? And then she in particular mentions Afghanistan as an example, but I think we may have seen this also in other countries. I think Somalia was briefly mentioned. We don't have anyone today, I think, from Yemen, but that's another case in point, a very difficult situation. And so how can we still find successful examples despite this lack of money, which is there? And then the other question is from Fuad Otman, asking me, how can we prioritize? I think several of you have highlighted, and also in your contributions, you say, okay, there's so many issues, there's everything, there's so many layers of things to be taken into account. And then he asks, well, how can you prioritize the interventions which are needed? Well, conflict is ongoing, is change, things are changing, and there's still this developmental need at the background. How could you then ensure that there's proper prioritization being done? In my mind, that is what the Nexus is about, but and have the right mechanism. But I think, could you, any of the panelists, kind of volunteer to answer one or both of those questions? I see Francesco.
Yeah, I can start, and then colleagues are going to be joining. Maybe just on to link up also with the pandemics. I think when it comes to the Global Fund and our contribution and development support, of course, from donors, I think we noticed that there is a different narrative now. I think most of donors understand how important and relevant it's actually supporting a health system, including in fragile settings, and community response in fragile settings. So that brings another investment case right now for the replenishment, that we are also aiming to increase our own allocation, therefore our own investment in countries, including the fragile settings, to support systems and focus on the community response. So from our side, I think we aim to increase our own support. Of course, our mandate is limited to HIV, TB, malaria, and health system, but I think we are aiming to increase that sort of element. And then when it comes to those specific challenges, because you mentioned before Afghanistan, but also Ukraine and how to transition, I think the fact of being on development side and engaging in early stage and emergency settings, we are at least having a visibility of a longer term investment in the country, and we're able also to catalyze extra funding and being able also to support. And we do have an emergency fund that's been used, for instance, in Afghanistan, when with the Taliban taking over, there's been some sort of a stall, and the Seta Hanmandi initiative was sort of challenged about the situation. We managed to mobilize funding to fill a gap for that specific situation. So I think that there are some ability and flexibility here and there that we can use also to secure that the flow of funding is continued. But this is, of course, from a development angle. Thanks.
Thank you, Francesco. Is there any of the other panelists who would still like to make a poll?
Yeah, I would. The question, the latter question in terms of how to prioritize. Yes, in a way, it's the essence of HDN. But one thing is, even in the extreme emergency where you're truly, just focused on the emergency, thinking if we can concentrate a bit on some of the policies and the potential consequences of what the actions may or may not do in the short and in the medium and the longer term. So it doesn't necessarily mean we have to start dividing up money or personnel, but rather thinking about things as simple as your humanitarian workforce. And so giving again Ukraine, thinking already about all of the healthcare workers, those that have stayed and what they've experienced, but many who have, particularly women who have gone into the refugee surrounding countries, already thinking about how to bring them back, retain them, keep their skills going. So I think there's a lot of policies that can occur, and thinking about what is happening now and what will be the long-term implications, and therefore maybe changing various policies that, while still the majority of the thinking and the money and the response can go towards the humanitarian emergency, as just one example.
Good, thank you, Paul. Nimo, a final word.
Thank you, Egbert. I don't know if I have an answer to this question, maybe just more complexities to add to the question. I think Ali or somebody mentioned it, but it's all about the political will. As Paul has been speaking to the differences between Ukraine and other protracted conflicts, might be to do with the foreign policy of the funders of those countries who are funding. And maybe, there has to be a way to focus, and also legislation. Counterterrorism plays a big role in how and who donors can actually work with in Somalia. So although there is exemption for humanitarian, it limits development side of it. And then you have this recurrent, predictable crisis that Somalia faces all the time, which is drought, actually water management. Majority of the time is drought, but there are certain periods where the rivers overflow and then flooding becomes the issue. So ensuring that for cost effectiveness, I think as well, to ensure that there's a little bit more investment in the development of these cases of humanitarian crisis that we know of, or partners or donors know of, just putting a bit more investment to ensure that the consequences are mitigated when they do occur, and they will certainly keep on occurring. So I think it's having that balance. Policies definitely play a big role, but I think if we look at it in terms of cost effectiveness to the taxpayers of the countries where the donors who are funding these humanitarian crisis that has been in the Somali case for 30 years, water tracking for 30 years, wash activities for 30 years, and yet the biggest problem that Somalia faces is water management. So I think we should look at it in the sense of cost effectiveness. So put a little bit more investment in the development sector will minimize the cost to the community, but also to the donor as well. I just thought I'd just add that bit. Thank you, and over to you.
Thank you very much, Nimo, for those final words from your side, but probably also from almost all of our sides. Unfortunately, time is already up as it goes, and I can see that several people, they do have to leave. So I think we should bring our session to an end. So that brings me to maybe give a final word to Ali to if you have something to round this up, not to summarize, that's impossible, but just a final word maybe, and then I think we can almost close.
No, thank you so much. Actually, that was such a insightful, fruitful discussion, and I think it showed that that's a difficult question to answer, how to implement the Nexus. Okay, there are many factors involved, some inside the health sector and many outside that actually dictate or direct us to some direction. But at the same time, there are opportunities that we can leverage. And I think we need more and more to document the lessons learned from the COVID. That's the subject of the webinar. And in that sense, I think what we can do, we can start with a summary of the discussion and basically post on the website of the FCAS and in other platforms, and then continue working together to share the experience, the documents of these lessons learned, and stay in touch. So I think with this small group, we can do great works. Thank you so much. Over to you.
No, thank you very much, Ali. I think I fully agree. We have been talking mainly about the Nexus at large, not so much about the COVID, but because we all know that there are so many different problems, not about the Nexus, but by the very situation we find ourselves in so many countries who are, as always in this kind of discussion, every situation is different again. But I think there will be still some lessons, and the COVID might provide a lens to learn from. So I think we should close our session with that lesson that we need to continue to the discussion, but also the learning, which I think it's very important because it's so fluid, and then the next thing pops up and then we move on. So I think it's high time to pick up the lessons and take them forward and retain them. So without further talking, I would like to close the session, but of course, first of all, thanks to all the panelists in particular, also to the participants for your contribution and your attendance, and hopefully some follow-up. And as said, we will try to make the session available in different formats. Probably the full session will be available, but also we try to have a bit of a shorter report, as well as some of the slides will be made available. You either will get a notice of that or just look at the website of the HSG. There's a section for our thematic working group, which it might be posted. And that leaves me to give a thanks to the secretariats of HSG to facilitate this session. Thanks very much for doing that. It's a great help. And yeah, I think that's about it. So we can do some waving towards those ones we can see. And otherwise, goodbye to you all.
Goodbye. Thank you so much. Thank you. Bye-bye. Bye-bye.